You next, sir.
Minister, in answering the Chair's question earlier, you said the government's ambition is for everybody to have access to an NHS dentist. Now that's a very big policy commitment you've made to us today, because obviously we're about halfway there with coverage around 50% at the moment. When do you expect to get there?
We maybe took it cross purposes. I said that we wanted everyone who needed an NHS dentist or wanted one to be able to access one. That is not the same as saying that every single person should be seeing an NHS dentist every 6 months, obviously. And I'm not quite sure what the statistic you're alluding to is. If it's patients seen per 12 months, we just had a conversation about why that's not necessarily the right measure, because we don't want, NICE's guidance is really clear that healthy adults only need to be checked up on once every 2 years. So we need to be clear about how we're measuring access. One of the things that I am very struck by at the moment is the greater difference between those who experience problems accessing a dentist when they want to, between those who have an existing relationship with an NHS dentist and those who don't. And that is one thing I'm absolutely keen to focus on, to tackle this problem about people who can't get an NHS dentist, and to improve that. And we can measure that. We can see at the moment how many people are taking on new patients, and we want to drive that up.
I don't think we're at cross purposes. I mean, I think we want to know how many people are able to access an NHS dentist when they need it. Mm-hmm. And you said the government's ambition is for everybody to be able to do that.
Yeah.
Now, the information we were given at the last meeting was that roughly half, slightly less, right, of the population can do that at the moment. So I'm absolutely welcoming the government's commitment to achieve that. When do you anticipate to get there?
I see what you mean. So one of the challenges in getting the right metric for this is it's about how far you have to go, right? So it's no good to say, oh, well, you could access an NHS dentist if you're prepared to drive umpteen miles. So one of the things we are thinking about as we work on our dentistry plan, as we think about how we make interventions, in particular interventions to improve matters where access is clearly worse. And there's a whole bunch of different metrics you can look at to understand how the NHS dentistry service is doing. But there are definitely patterns in the data where there are some places that I think are struggling on a bunch of different measures.
There certainly are areas which are worse. We talk about dental deserts. Most of the rest of the country are just kind of barren ground. There are no green pastures, are there? Because every MP is reporting constituents coming to us saying they simply cannot get an NHS dentist. Now, you've set out an ambition today that the government wants to ensure that everybody has access to an NHS dentist. My question is, when do you intend to achieve that by?
Well, as soon as possible is the only possible answer to that question. So my point back to you is I'm not being obtuse here. It's just that in terms of measuring the quality of access and how long people have to travel to get access, and therefore how easy it is, there's other measures as well one could use to check out how easy it is. We do need to get the measures of this thing right, particularly if we're going to base particularly focused interventions on different measures. We need to make sure that we're calibrating that in the right way so that we don't distort things. But absolutely there is actually, I think, quite a lot of variation around the country between places in which people are not having to travel long distances and some places where they are having to travel too far. And we want to reduce that variation and improve access, particularly where it's weak.
I accept that metric into your point about unacceptability of having to travel long distances. And I think that when you set out an ambition like everybody should have access to an NHS dentist, the expectation would be that that was in reasonable travelling distance. So it's your ambition to achieve that as soon as reasonably possible. Now, clearly, the dental contract is critical to that because we are hemorrhaging dentists from NHS service. Not dentists, but people, and Dr. Doyle is nodding.
I'm not sure what that's based on. The number of people doing NHS work has gone up. The question is how much NHS work they do, and that is best measured by the delivery of UDAs and the number of patients seen, and both of those things are going up. So it's true that the service took a tremendous hit, more than any other medical service during the pandemic, because of the nature of what it is.
I think we would find it helpful if you could kind of give us the data to confirm what you've just said? Because
absolutely.
the evidence that we've had is that actually we're losing dentists from NHS delivery. And Dr. Doyle was nodding when I made that point. But I
don't think she was nodding, actually.
So we know that just above 70% of dentists on the register are offering some NHS service. Again, as the Minister said, the difficulty is we don't know how much private activity dentists are carrying out. All we can measure is how much NHS. What we do know, which is starting to improve things, is, so when we look at patient satisfaction with access and the number of patients who access dental care, what's really clear is people who already have a relationship that's established with a dentist, even though dentists no longer register patients as such in the same way GPs do, but people who have an established relationship found it very much easier to actually access care when they needed it than people who didn't have an established relationship. But we are starting to see some improvement, partly because of the ways in which we've all talked about we're trying to either increase capacity or make the best of the capacity we've got. We know that in February of this year, 86% of dental contractors saw at least some new adult and child patients. So 86% of all dental providers saw some patients who were new to them, who didn't have an established relationship. Our aim to catch up with the backlog of people who are trying to access care, and obviously those are more likely to be people who've got a dental need rather than people who are just trying to have a checkup, for example. We are starting to see some recovery in that.
Thanks. Can I just, I appreciate that, but it would be useful if you could provide the committee with the stats to back that up, because it conflicts with some of the evidence that we've had. Of course. So, but let me just continue pursuing the Minister, if you wouldn't mind. Because I thought you made some very good points, Minister, critiquing the current dental contract. And you said, and I wrote it down, you think that we should fundamentally overhaul the contract. And I certainly agree with you, because the reforms that were made last July are just kind of tweaks at the edges. Could you just give me, say, 3 points that you think would be central to a fundamental reform of the contract, so we get a proper sense of where you're going?
Absolutely. I would dispute that what's been done so far are just tweaks. They are important, but they're only a start. So I think things that are important as we try and overhaul the contract are, firstly, to think about unjustified, unhelpful variation in how much people get paid for the same amount of work. Everyone knows about the variation in UDA rates, potentially even along the length of one street, but particularly between different regions. So that's the first thing. I think a second thing that we need to address is this problem that I raised right at the start of the session about the complex patient who might be more suited for capitation of a kind. And people, or other places, are starting to address that with solutions like sessional and access payments. But I do want to think further about whether we can do something that isn't just about a one-off course of treatment and bang, you're done, but it's about looking after someone over a longer period who has a more complex need. So that's the second thing. And I think the third thing is just fundamentally to try and further improve the match between the cost of providing the work and the cost of that they are then reimbursed for. Because when I talk to dentists, they are very conscious of this, and they feel very hard done by if they feel like they're doing NHS work at a loss, even though a lot of them are incredibly public spirited. And when, in particular, when I talk to them about taking on new patients, it's clear that their fear of taking on new patients in some cases is that they will get a very complex patient who will require very complicated work, and that the current contract will not sufficiently remunerate them for that not to be a loss-making exercise for them. So tackling that is quite central to tackling the question of kind of taking on new patients. That would be my take on it, but others, I'm sure, the panel would have.
So I think perhaps one of my disappointments is that having made a policy supported by the government and currently published on the NHS webpage, which absolutely deals with how a practice can support a high needs patient through what is currently called phased courses of treatment, but actually is realistically a personalised care pathway. That guidance has been there since 2017, which allows an approach that supports a patient through, and you've got to be a patient with high needs, and that's not just you need 3 fillings, but a patient that needs to be disease managed, for want of a better description, that needs to be supported from stabilisation to functional restoration to definitive restorations. That's possibly going to take a practice a year to work with that patient. Now, under the old system, if you just said it, that was 3 units of dental activity, possibly 12. But actually, since 2017, we've laid out quite clearly how that approach can be taken, and you can take a patient through a series of phases where the practice receives a remuneration, but with the recall required for these high-risk patients, actually doesn't trigger a second or third payment. So up to 3 courses of treatment can be provided for that patient in a year. That has been there, and we revised it coming out of COVID in 2021 to also encompass the work for gum disease, because again, that's another piece of work. It is to my disappointment, despite the BDA sitting round the table when we designed that policy, that less than 0.1% of the claims that go through BSA of that phase course of treatment. That is an opportunity that practices currently have to be able to take on a high needs new patient. I can take the horse to water, but the practices need to be making these decisions given the facilities and the policies we've made available to them. I've already discussed, the capacity that we're utilising at the moment in terms of, dare I say, a discretionary or possibly even an unnecessary checkup. 70 to 77%. That's capacity that could be used for high needs patients, patients in need. So there is flexibility at practice level. There is flexibility at provider level. There's flexibility at ICB level increasingly to be able to support that.
The contract has to incentivise dentists to do that. And I wonder if I could just push the Minister further on UDA rates in particular, because you've talked about, and I agree with you, about the importance of sorting out the disparities. But you've talked about it in the context of regional variations, and when Paul was talking earlier, he was saying it's about getting dentists to move to different parts of the country. I could take you to 2 practices about a couple of hundred yards away from each other in my constituency, where one is got a UDA rate of just over £20, and the other's about 35. Now, that has an impact on, and it's a similar demographic, they're only a couple of hundred yards away. That has an impact on which of those practices feels it can continue to do NHS work and which it feels it can't. In your fundamental overhaul of the contract, do you intend to sort out those disparities and normalise the UDA rates?
So, just before I come on to answer your question directly, it's important to not lose the importance of what the CDO was just saying about phasing, because in theory at least, we have the solution to this problem about the course of treatment being an obstacle, because you can use phasing, and the guidance was updated by CDO to do that. So you can just consecutively run courses of treatment and get paid as much as it takes to make a person better dentally. Whether whether the route to fixing that problem involves us doing something further with phasing or something else is I think an open question in my mind.